Thank you very much. I would now like to invite Dr. Deininger up to the stage to present updates on CML.
So, morning everyone, and having me here. I took the liberty to deviate a little bit from the strong focus on clinical trials, and I will tell you why I think this is okay. The reason is that this is a very mature field, and I think it creates some challenges that are not unique to CML, but CML can be used as a paradigm to illustrate them. And so bear with me, and if I go too long, then start shouting and throwing stuff at me, and then I'll let you out for coffee. So this is an old and a long-standing field, but there are still a couple of frontiers. That's the management of advanced CML, treatment-free remission, and access to care. Now, first of all, we look at another round of definitions of accelerated phase or blast phase. And I have a pretty cynical view on that, because I think we're just getting stuck here. So it doesn't really fundamentally change anything, but people can, we can agonize over that forever. So I think the critical point to make is that blast phase of CML or advanced phase of CML is a phenotypic conversion. The same phenotype based on very diverse and different acquired somatic mutations. And the point to make here is that essentially this is only a two-phased process. There is a chronic phase and there is an advanced phase of CML, but it's a continuum. So once you go out of the chronic phase realm, you approach something that presents in various ways, but is clearly different and more malignant. So CML equals two phases, not one. And that comes in various flavors. So for instance, advanced phase CML, this is also patients who failed TKIs. Although morphologically, they may still fulfill the criteria for chronic phase. And you can look at that, as we did here in this study, by looking at gene expression, and you find a lot of overlap between what you find in patients who failed TKIs or who are bound to fail TKIs, and patients who are already progressed to morphologically advanced phase. So the biology is very similar, and I think that's something to remember. So what scenarios of advanced phase do we still have? So number one is primary or acquired TKI resistance, but still chronic phase criteria met. Now, if you look at these patients, we have pretty good treatments available. This study has been presented yesterday as well. It's the PACE trial of ponatinib in TKI-resistant CML at various phases. And what you look at here is the patients who got on ponatinib in the chronic phase. This is progression-free survival, this is overall survival, and this is broken out according to mutation type. And you see that I think it's all in all not too bad. So we look at about 80% overall survival at 72 months. Now, the problem, of course, with ponatinib is that soon after that, it got a really bad reputation because of cardiovascular toxicity. And as you may remember, in 2013, was even pulled off the market in the United States for several months. So this trial also talked about yesterday, the OPTIC trial, now used a new principle, and I think it's a good principle. It basically deviated from the paradigm, once you have a dose, you just keep on giving that same dose irrespective of response. What this trial did is to say, okay, we start everybody on a fixed dose of ponatinib, but then as soon as we have the desired response, people are programmed to reduce the dose. And also if they have toxicity, of course. And this programming is basically leading to this three-armed design. So you start at 45 milligrams at 30 or 15, and then on achievement of BCR-ABL level of less than 1%, you go down with the dose. Excuse me. This is the results of that trial, and you look at the three arms here, and you see progression-free survival and overall survival are not really very different from each other. So that means we can actually do this, and we don't need to start everybody on the highest dose available, and it's okay to reduce the dose in a programmed way, in addition to responding to toxicity. Now, subsequent analysis of that study, post-hoc admittedly, allowed us to become even a little bit more sophisticated. And the two parameters that came out of this are the initial BCR-ABL level, 10% or less, and the presence of a T59 mutation, other mutations, or no mutation. So patients with more than 10% of BCR-ABL prior to therapy, this is dying, they really benefit mostly from the 45 milligram starting dose. If you don't do that, the response rate drops pretty dramatically. On the other hand, really similar, if you have any type of mutation, BCR-ABL, T59, or another one, or no mutation, if you start with 45 milligrams, it doesn't make a big difference. If you start at 30 milligrams, you do still reasonably well with no mutation or other mutations. Sorry, this is really poor guy. It's really, he doesn't look very good. But if you have T59, the response rate drops. That's the blue bar in the middle. So you need to do these two tests, relatively simple, and then you can stratify your patient, and you pick the right dose to start with. So I think this is one of the ways to go here, really looking at a relatively limited set of initial data, and then you can make these treatment decisions. So another question, of course, equally important is whether this adjusted design allows you to reduce cardiovascular toxicity. And by and large, the answer seems to be yes. This is grade 5, 0% or 0 events in all 3 arms, and then grade 3 to 4 is much lower than the 28% reported incidence in the PACE trial. So I think this is a good trial because of that, and it may be applicable to other scenarios as well, where we still tend to kind of keep going on the highest possible dose if the patient tolerates it well, irrespective of the response. So another really exciting development is a drug called simonip, or previously ABL001. Now, as you may know, the so-called conventional TKIs, they all bind to the ATP binding pocket in the ABL tyrosine kinase. But this molecule has an allosteric pocket that is quite a bit away from this ATP binding site. And that regulates ABL kinase under physiological circumstances. So normally ABL is in a closed auto-inhibited conformation. Now, if you replace the ligand that normally binds here with a small molecule called simonip, you can essentially force the ABL kinase into this auto-inhibited conformation and shut it off. And surprisingly, that works even in BCR-ABL, in the activated oncogenic version of ABL. So the phase 1 trial of simonip is a very complicated study, and the initial results of the study have been published a few years ago. And so it was good to see an update of this trial. And that's just come out a couple of days ago in leukemia, where we look now at patients only limited to those with a T59 mutation. There are 2 points I would like to make here. First, I really like the colors. Second one, if you look at this thing here, this is basically lines of treatment. I think what we all need to appreciate is that this is getting really complicated. And each of these patients has, or not each one, but many of them have a very individual history. So knowing the history of a given patient is probably telling us a lot about what the disease is at this given point. And there is a certain limitation as to what you can capture in terms of data derived from a single time point. So without knowing that, you really don't get the whole history of the patient. And I think this is going to haunt us in a major way in CML, but even more so in diseases like multiple myeloma, where patients may go through 7, 8, or 9 lines of therapy. Second point I'd like to make here is that we sometimes tend to say, well, you know, these side effects, they disappear with time. They don't really. If you look at this one here, this is side effects. I think it's musculoskeletal pain according to year on treatment. It doesn't really change that much, right? So I think these chronic side effects, I think in contrast to what we'd like to think, they don't tend to go away. And it's something to really bear in mind. And if you now look at the results, I think they continue to look quite good, with one exception. Those patients, let's just look at MMR, with more than 10% BCR-ABL prior to therapy, they do less well. So they are less likely to achieve MMR, and they are less likely to have an event-free survival. So this 10%, something is magic about it. It really means something, and I guess the 10% threshold identifies that those patients who are truly resistant. So this is a biologically different group, which conversely means that those patients who have 1%, 5%, 3%, they're probably still responding, so they're not truly resistant. And that implies that sometimes a very aggressive approach to these individuals may not be the right thing to do, but 10% is clearly defining a different group. So how does asciminib stack up compared to conventional therapies? This is the assembled clinical trial. This is a nice study with a big problem because it's been designed to compare asciminib versus bosutinib, which is arguably not the best third-line TKI, which is ponatinib. But at the time, the ponatinib dose wasn't quite clear, so that design was chosen. It also implied that only patients who did not have the T59 mutation could be included. So with these caveats, this is a very straightforward design. Now, another peculiarity here is that the primary endpoint is MMR at 24 weeks, which is really early. So MMR, you're okay. No MMR, by trial definition, you fail. So let's just bear that in mind. This is data now at 48 weeks, so already twice as long as the primary endpoint. And you see that the experimental arm does better compared to the conventional arm, with significant difference. Now, this is really significant, but does it really mean that everybody who is not an MMR at this time is automatically a failure? I would say probably not, because most people with BCR-ABL of just less than 1%, equivalent to a complete cytogenetic response, have good long-term survival. So in a way, we've kind of bitten ourselves in our own tail here by being too aggressive with the primary endpoint, and now we have this notion that all these patients have failed, but most of them are likely to do just fine. Which is, this is side effects. Very quick. Asciminib is really well tolerated, bottom line, okay? If you look at overall survival, that slide has come out for some reason. It's good for both arms, which implies that those patients who fail by clinical trial definition criteria actually still have pretty good outcomes. So another molecule to keep in mind is, has a really complicated name. It's called Overem Battnip. And it's a drug that has been developed mostly in the People's Republic of China, with one phase 1/2 trial published a couple of years ago. And this trial included patients with a T59 mutation. Adverse events are relatively mild, with the one exception of skin pigmentation. And I really don't understand that quite frankly, but it's something very peculiar. So we don't know really what it means. It included patients in chronic phase and accelerated phase. It's a little hard to read. Focus on the green curve here, because this is MMR, which we would use as an endpoint in most of these trials. And you see that this is roughly 50% in chronic phase and about 35 to 40% in accelerated phase. This is overall and event-free survival here. So looking quite good. Now, is this a fundamentally different drug? The question being, can this drug salvage patients who fail ponatinib because it's active against T59? And the data on that is relatively limited, especially the data generated in the United States or in the Western world. So this is an abstract that has been was presented at ASH. It's hard to read. But by and large, it seems that there is significant activity even in patients who prior to that failed on ponatinib with real resistance, so not just because of intolerance. I find that sort of hard to believe, but so I'd like to see a little bit more data because the differences between these two molecules are really minor. So basically what they did is they just switched the imidazole ring and the pyrimidine ring and changed the position of one of the nitrogens. And this is in a domain here of the molecule that is not that important for binding to the target. So let's just, look at that with a little bit of skepticism, but so far the data look really quite promising. So next topic, what about if there is accelerated phase or blast phase criteria met at the time of diagnosis? Arguably, that is a space where you don't have a lot of data, unfortunately. And it's a problem that is particularly prevalent in the developing world as opposed to the more privileged Western world. In India, for example, it's estimated that maybe as much as half of the patients are diagnosed in accelerated phase or blast phase. So I just wanted to use that moment to make a point about the initial assessment, because what we see increasingly is that people, the only diagnostic they have is fish on BCR-ABL on the peripheral blood. And I don't think this is good enough. And one of the key reasons for that is that if you pick up a so-called major route abnormality, an additional cytogenetic change in the pH-positive cell clone at the time of diagnosis, you have much higher risk. This is a Posthoc study done on the CML4 trial from Germany, and this is the green curve here. This is overall survival of those patients with these major route abnormalities at the time of diagnosis, and I don't really have to belabor that. They are a much higher risk group, and they need much more, attention, if you will. Now, importantly, this trial here from China is the first that I've seen that really looked more systematically at the outcomes of patients diagnosed in accelerated phase. It's relatively well powered with over 200 patients on this study, and it was able to look at responses, major outcomes, and then also do multivariate analysis to try and identify those patients with accelerated phase who really behave more like blast phase. And it turns out that with relatively simple criteria here, you're able to identify this high-risk group here of patients in red who clearly need a different approach. So I think this is a very useful trial that will help us in these rare circumstances where we have a newly diagnosed patients with advanced phase CML. A very peculiar thing is that the basophils here, where is it? Yeah, basophils. So I always thought about many basophils, this is bad. In this MVA, many basophils all of a sudden are good, because if you have less than 3%, you do worse than if you have more. So it's one of these strange things that we have to maybe observe a little bit longer. So outcome according to initial TKI, bottom line is it doesn't really matter that much, probably reflecting the ability to salvage effectively in patients who don't respond accordingly. The general outcome of blast phase CML, however, is not very good. This is the biggest study, MD Anderson, about 500 patients, and they were able to do this multivariate analysis, and you see that achievement of CCYR and combination of TKI with chemotherapy in the management are favorable, and a number of prognostic parameters are unfavorable. But it really is still the case that if you progress into blast phase while you're on a TKI, your outcome is very poor, all in all. This is a little analysis of the NSND study. This is NSND compared to IRIS, overall survival after progression into blast phase on treatment, and I don't have to comment on the curve. Same in the PACE trial. This is blast phase CML, Ph-positive AML. Most of these patients will not maintain remission long term, but will relapse and then eventually die within 6 to 12 months. So the answer is still allogeneic stem cell transplant. And it's one of the few indications where I think I personally have very little doubt. So clearly, if you transplant while a patient is still in chronic phase, the outcomes are a lot better. In fact, once there is progression to blast phase and you transplant patients in overt blast phase, the outcomes tend to be very poor. Some of the studies actually show 0 survival. And this is both high relapse incidence, but also extremely high transplant-related mortality. So we need to do everything to prevent progression to blast phase in the first instance. This is, again, a little subset analysis from this German CML4 trial. This is advanced phase, progression first, then transplant. This is elective transplant in chronic phase, and clearly the outcomes are a lot better for the latter option. So this is how I currently look at that. This is debatable. Some people will have different opinions on that, and not everything here is strictly data-driven. I think in chronic phase, I would not consider first and second line failure, but only third line failure as a potential indication for a transplant. Even that needs to be carefully considered. So we tend to take an algorithmic approach, and I will tell you about 2 scenarios that really give me headaches and let me lose sleep at night. So one is what to do with these guys who present with aggressive accelerated phase, but then do really well, have a really great response to TKIs. And you basically say, okay, I want to transplant this person, and then the response to treatment tells you otherwise. Now, how safe is it to do that? And secondly, those patients who progress into accelerated phase go on an alternative TKIs and then again have a really good response to that. Because we know once we see this sudden progression, they drop in their overall survival post-allotransplant very, very dramatically. And so how do you advise people like that? I struggle a lot with that, and unfortunately, I don't have a solution. So what's next? There's investigational approaches to blast phase, a lot of them. I don't think we've really have any total breakthrough, but I will tell you 2 little things that we've been focusing on in our lab. The first one is that question of what is this blast phase that fails our best TKI, ponatinib? Turns out that in about half of these patients, you have reactivation of BCR-ABL signaling, typically through a mechanism that we refer to as a compound mutation. And there are other patients who don't do that. So they should still be responding, but clinically they are progressing despite maintained suppression of BCR-ABL kinase. And we call that BCR-ABL independent resistance. So in terms of these compound mutations, they combine 2 mutations in the kinase domain. And it turns out if one of these 2 mutations is T59, that creates a highly resistant kinase. So everything in red here are these double mutations, compound mutations that have T59 in them, and that's all red, so means it doesn't really do anything in terms of responding to TKIs. Turns out that they are rapidly selected on therapies. This is a patient treated with ponatinib. You have this little clone here with a compound mutation. After 6 weeks, in the transient response, it's grown out to dominance. And then you can do structural modeling, and you can really explain why these compound mutations change the structure of the kinase in a way that disallows binding of ponatinib. So biologically, that makes a lot of sense. Now, what we've been looking into is the question whether you can combine this allosteric inhibitor, simonip, with ponatinib and maybe recapture responses. And surprisingly, that seems to work really well. So I will just talk about this one here. These are the 2 curves here, simonip alone and ponatinib alone. And you see you need huge concentrations of inhibitors to see anything, but if you combine the two, that's the blue curve, you shift this curve dramatically to the left. So the combination does just a lot more compared to each agent individually. The problem is the concentrations of ponatinib you need are still difficult to achieve in patient plasma. So you really have to push 45, even more than 45 milligrams to get there. So the question is, can we get a replacement for ponatinib to have a less toxic alternative? And the way we approach this is to use something called quantum similarity modeling. And I personally don't understand it, but we have a collaborator who is really good at that. But what it does in a nutshell is it uses an algorithm to project the shape of small molecules by looking at the electron density. And if you do that, it turns out that the chemical structure of molecules can be very different, and yet they can be very similar using this quantum similarity modeling. And that opens a number of possibilities. So you can basically use published structure data and then just tell the system, hey, find me all the molecules that look like this compound that is in the structure, but is just different. And you don't care about the chemistry. So we did that, and we're able to identify this molecule called LY333009120, which is actually a RAF kinase inhibitor currently in trials for solid tumors. That is much narrower spectrum compared to ponatinib and has decent pharmacokinetics. So if you compare the efficacy of this compound with the efficacy of ponatinib, both combined with a simonip against compound mutants, it looks quite similar. So the upper, I think, is this LY, and the lower is ponatinib. And you look at synergy scores, so blue is good. It looks quite similar. So we think we can possibly replace ponatinib with this molecule if we can convince the company to allow us to do this trial. Another approach is BCR-ABL degraders. You may have heard a lot about that in other worlds, such as breast cancer, BET inhibitors, for instance. So it's been a bit challenging to make these degraders, but we have initiated a collaboration with a collaborator at Madison, and we're able to identify a pretty strong compound here that really does away with BCR-ABL in a very impressive way. That doesn't really touch BCR-ABL negative cells, but is highly active against BCR-ABL positive cells. So maybe that is something to watch in the future, and that, of course, would do, at least theoretically, more than a kinase inhibitor ever could, because it would remove the protein and all other functions that the protein itself could have that are not related to its kinase activity. So lastly, treatment-free remission and access to care. And I really like to think about those combined, because the question that we are looking at is it free treatment, that's access to care, or is it treatment-free, that is treatment-free remission? And I think we have to face a situation where our resources to do research are ultimately limited. So we have to think more carefully of where we put these resources. It took me forever to do that, but I think I'm actually really proud of this. So let's look at the CML landscape in privileged countries. I think the perception is of a solved problem. Prevalence is increasing. Prospect of indefinite TKI therapy still for the majority of patients. Therapy setting clearly moved from academia to the community. Ongoing struggle with highly inflated drug prices. Important questions moving outside our typical expertise. Reduced research funding, less interest to do a CML career. This is Sweden. And if you are diagnosed with CML in Sweden, your survival really approaches that of the general population without a CML diagnosis, which is great. And this is many times the data we cite. If you live in India, of course, it looks very different for you. And if you believe these projections here, there is an increasing incidence, probably reflecting by a better diagnostics, I guess, not necessarily a biological increase, and a huge increase in the number of patients. So I think we have to face some really tough questions. Where do we have the most impact? And although I'm personally really excited about single-cell genetics and all this stuff, international work with improving access to care and diagnostics is going to make a way bigger difference. I think, I don't know where this is coming from. I think they just made it up, of course, but I think it really looks very impressive to say the R squared is close to 1. So, but let's look at our own backyard. This is SEER data from the United States of America, and I don't want to go through all these curves, but clearly if you're a Medicaid patient, you do a lot worse than if you have insurance, or you are on, or even if you are uninsured, or if you are older, or if you are a black, non-Hispanic, you do a lot worse. And there are other studies that, you know, confirm that. So compared to Sweden, in our society that spends an incredible amount of money on healthcare, we don't really do so well with treating CML, which arguably is the cancer that is the most treatable of all. So I think it's time to, you know, to really think about how, you know, how on earth can this happen? So another realistic view is here. This is CML Publications on PubMed with, you know, where CML is in the title, and you see the heydays are over. This is CML as a proportion of AML, CLL, MDS publications. And this is research funding, CML, AML, and pancreatic cancer. This is only NIH, or National Science Foundation. So resources are getting more limited. So maybe we need to reconsider some of our approaches, and I really want to be quite self-critical here as well. But one question that I have is, when do we actually know enough about the same thing? So my paradigm here is the impact of the BCR-ABL transcript type on various outcomes. So these are all studies that basically look at the same thing. And patient numbers included, they range between 69 and 45,503. But the results are pretty much identical. If you have a certain transcript type that is B2A2 in the old system, you do worse. Okay, I think we can just say we've understood that. The second thing is sometimes we get obsessed with details. So this is a Mandelbrot system, and you look ever closer, and after you can blow that up time and again, and you will always find more details. But it doesn't necessarily mean that this is knowledge we need to have, especially in times of limited resources. So, in fact, not everything that is knowable is actually worth knowing. So this publication here on propofol effects on inhibiting PI3 kinase signaling and in increasing TKI effects concluded that propofol has potential to be repurposed for CML treatment, which of course I doubt, because as you know, well, it does propofol. It's not all good about propofol. Okay, so and then lastly, treatment-free remission. There are a few questions that I really have. Will we ever be able to predict who is going to be successful? Do we use the right disease models? Is TKI plus something else really the answer? And are we really translating all these beautiful preclinical data? And I'm not sure if I can get this started, but probably not. But what I wanted to show here is the following. Some of this stuff is basically probably impossible because the initial states may be so close to each other that we cannot really distinguish them. And if you see it, just go online and ask for a one pendulum, a two pendulum system. So if you have one pendulum, it's pretty much in sync for a long time. If you have two pendulums, okay, can you activate this thing here? Perhaps, probably not. I can't. So what I'm trying to say is that there is, And now the second one as well. Okay, so let's just enjoy that for about 19 seconds. And what you will see is that this system on the right behaves very different, although it doesn't seem that different. So the outcomes after a short while are totally different. Now already it's doing totally different things. So if you wanted to predict based on a very small difference in a complex system like that, an outcome that is 2, 3, 4, 5 years ahead of us, away from us, I think it's almost impossible. There are just too many variables. So this is probably never going to be possible. So the real worry here with TFR is that some of these curves are not really plateauing, so patients are still relapsing. Unfortunately, that is different from what the clinical trials have told us. So it means that patients need to be in continued surveillance. And then lastly, the Holy Grail, targeting CML stem cells. And I'm not expecting anybody to read this. It's all studies that were published over the last 2.5 decades that found an important mechanism relevant for the survival of CML stem cells. And I have more. The yellow ones are those that actually were tested in a clinical trial. So look at that. Only a small minority. On this page, only 3 out of 10. On the next page, none. So if you do the math, and it's probably not complete, we have 24 targets, 18 we never tested, 6 we tested, but 4 of them not really in the right clinical setting because we went after accelerated or blast phase, probably really hopeless. And we tested only 2 in the relevant setting, and only 2 reports came out. So clearly we have a major block here in translating preclinical knowledge into clinical trials. And I think we have to be, just have to get better at that because of the limitations. And another realization, it's okay, right? So mice are good models, but they sometimes really have different biology. I'm not going to tell you about the studies specifically, but it's basically just the opposite in mice compared to humans. And still, the preclinical mouse model was the reason to initiate a phase 1 trial without looking at human samples. So I think for the community, this means we cannot allow stuff to be published in high-impact journals without demanding validation in human cells. I think the community just needs to do this. And then lastly, it's just messy. So BCR-ABL independent resistance is messy, multiple clones. I think if you really want to dive into that, we have to get out a much bigger microscope and look at single cells. It's one of the things we are trying to do in the lab, but I will not bore you with that. So I want to end on a positive note. So for a long time, of course, we have kind of accepted that inhibiting BCR-ABL is going to leave residual disease no matter what we do. But there are a few things that are actually sort of hopeful. One is this abandoned trial called the EPIC study that was a frontline trial comparing ponatinib with imatinib, with an initial ponatinib dose of 45 milligrams. And this trial then was abandoned because of the cardiovascular toxicity of ponatinib. But if you look at the molecular response rates with ponatinib in this trial, although the data is very limited, they are dramatically better than what we saw with any of the second-generation TKIs. Now, this didn't go anywhere because the toxicity is just unacceptable, but it, in a way, shows how far we might be able to get just by effectively inhibiting BCR-ABL. And now with this new molecule, simonip, available that has way fewer toxicity issues, we might be able to actually test that. This is one study that was published at ASH. I don't think it's easy to see that. But if the take-home message is that asciminib in the front line in newly diagnosed chronic phase patients has dramatically improved molecular response rates even after 3 months. So I think it's going to be interesting to see how much we can accomplish just by effectively inhibiting BCR-ABL with this new molecule. And so maybe there is hope to eventually turn a lot of patients, more patients, into treatment-free remission responders. And with that, I just want to acknowledge all the collaborators that I had a pleasure to work with over many years. I'm actually not at Utah. I'm at Milwaukee now because somehow I'm still at Utah, but only on paper, so I'm really in Milwaukee. And I thank you very much for your attention. So.
Thank you very much. We will now have a quick break and then meet back in here to continue the day.